right, well, we're ready to get started with our first ever hybrid event. So bear with us, we're learning. We're excited to see all of you online, and of course, we have our room of our folks that came here from the Raleigh area, and we're just really happy to have you here tonight. I'm Paige Humble, and I'm the Chief Executive Officer of Lung Cancer Initiative, and we're here tonight to talk about biomarkers. And someone asked me earlier if we've ever done an event about biomarkers specifically before, and we actually haven't. So we're very excited to be able to talk with you all tonight, and we have some great speakers to share with you. I don't think this is working, my little controller. Let's try this. One moment, we're going to switch slides here. Thank you. So tonight would not be possible without our sponsors, and so I want to say a thank you to everybody who's our partners and who are our sponsors that are making tonight possible. And we have some of our exhibitors here with us in the room as well. Are you going to control?
So is this thing still not working?
It's not. It didn't work. Let's try this again. Yeah, it's not working. Okay, sorry about that. Thank you. We're also here because it's Lung Cancer Awareness Month, and so we have white ribbons that you can wear tonight. We have some T-shirts and things. If you're here with us in the room, you can grab before you leave. But we really wanted to do this event during Lung Cancer Awareness Month because we've been seeking ways to continue to raise awareness across North Carolina and beyond. And we want to say a special thank you to G1 Therapeutics, who is our first ever Lung Cancer Awareness Month sponsor. Slide. So our mission at Lung Cancer Initiative is to advance survivorship and provide support to those affected by lung cancer. And we really focus in several key areas: research, education, and access programs. Slide. Slide. Oh, thank you.
I just say one more point for the whole hybrid thing. There are mics on the tables and they are on. So if you're like talking, just be aware that the mics are on the tables.
Thank you. So when we talk about our programs, I just want to give you a high-level overview of who we are at Lung Cancer Initiative. We fund research grants, so we fund research fellowships at each of the 5 major medical institutions across North Carolina. And our goal with our research fellowship program is to fund researchers early in their career in the hopes that they go on to receive greater research funding. And now that our programs have been established for a few years, we're seeing that happen. So that's very, very exciting. We also have an innovation research grant, and we also have a career development grant for someone who's more mid-career. And actually, Dr. Patel, who's one of our speakers tonight, is a recipient of our Career Development Award. We have survivorship programs. Several of you in the room, and I know several of you online, have participated in those programs. During COVID, we launched a luncheon series. So we have luncheons once a month online for survivors to connect across the state. We have an annual survivor wellness retreat. Again, some of you who are here today have participated in that. We have a Survivors Day celebration, and we always are looking for other ways to connect survivors across North Carolina. We have access programs, so some of you may be familiar with our gas card program. We offer $50 gas cards up to 3 times a year per patient to help patients access appropriate care and treatment. During COVID, we also launched a patient emergency fund to help patients access their basic needs, and that's a program that we see continue to grow. We also have what's called our REACH grants, and that's really a way that we can partner with community institutions to help them facilitate access to education, to treatment, to clinical research, to biomarker testing, and we do up to 3 of those each year. And then we have educational programming, so events like tonight. We also have other programs that we offer across the state. During COVID, we've largely done them virtually, but historically, we've gone into local communities and partnered with local cancer centers to offer education. We also have our Advocacy Summit. So I encourage you all to check back with us next year. Jenny, is it May for Advocacy Summit? We are going to be offering the summit in person next year, and it's a great way to arm yourself with tools to go back to your own communities to be more effective advocates. Next slide. Thank you. So just a little bit more about research. To date, we funded more than $2.6 million toward lung cancer research. Last year, we funded 7 researchers, and I mentioned our Innovation Grant Award, and that's a newer grant for us, and so we awarded 2 of those last year. Next slide. And access, I just wanted to show you the coverage of access. So we had a goal to reach all 100 counties through our gas card program over a 3-year period. And you can see all the counties that are in blue here, we were able to reach during that 3-year period. And so we're starting over now, and we're very excited. You can see here in 2020, we were able to reach patients in 75 counties. Next slide. In education, I gave you a little overview about our summit and our educational programs. What I will say to you is we love to hear from you all about what you want to learn about. So even after tonight's program, we would love your feedback on future educational programs that we can partner with you all and your communities on. Next slide. And we love to advocate in so many different ways. So we like to participate in local health fairs. We like to partner with the local media. We have partnered with some of our industry partners and toured labs and looked at how biomarker testing is done. And we've also gone to a lot of conferences. And as conferences start coming back, we're very excited. This winter, we're going to the North Carolina Academy of Family Physicians to talk with primary care providers, for example. So we look for we have diverse ways that we try to partner with folks across North Carolina to raise awareness and to advocate on behalf of the lung cancer community. Next slide. And I want to invite you all to our open house at our brand new offices on November the 30th. Right before COVID, we moved into a new office space that actually afforded us some classroom space in our building and a much more efficient space for us to be able to use for things like this. And now that we're able to get back into the space, we're ready to open up and invite folks back. So if you are in the area, we would love to have you join us on Tuesday, November the 30th. From 4 to 6 p.m. We just ask that you RSVP because we're still trying to plan ahead because of COVID and want to be sure that we're prepared for the group that's coming. So please join us if you're able. Next slide. Excellent. And so now on to our speakers. So I have the pleasure of introducing our speakers tonight. And I'm going to go ahead and introduce you to all of them, read their bios. I think you have this in your agenda too. Everybody's got their more detailed bios. But it's my pleasure to introduce Terry Conneran, who's here with us. Since 2017, Terry has been battling stage 3 lung cancer. Eventually, the biomarker that was causing her non-small cell adenocarcinoma was identified as a KRAS biomarker. Unable to find a support group with others on a similar journey, she founded KRAS Kickers in 2019 to create a network for patients and families in search of KRAS information and support. So we'll hear from Terry in just a little bit. And then Dr. Shetal Patel, and I don't believe she's here yet, but she's on her way. She's Assistant Professor of Medicine at the University of North Carolina at Chapel Hill. And she's also one of LCI's research fellows and the recipient of our Career Development Award in 2020. Dr. Patel's project aims to test novel treatment combinations with the hope of improving immunotherapy treatment outcomes for patients with lung cancer.
Well, thank you, and I'm sorry for being late, running a little late in clinic today. So my name is Shetal Patel. I'm one of the thoracic medical oncologists at UNC, and I wanted to just give an overview of, coupling with something that's already been presented about what is involved in comprehensive biomarker testing, and ultimately how we're using this to treat patients. So first is talking about what are biomarkers, and you've heard a little bit of the flavor of this already, and we'll talk about two big main areas of buckets that we're going to be looking at to decide on treatment, approaches to testing, tissue versus liquid, and then what we are really looking for in a comprehensive test as a treating patient. So to start off with, let's go through a patient case that may present to our clinic. So this is a patient of mine, a 47-year-old gentleman, limited smoking history, who presents with several months of cough. Ultimately gets some imaging and a CAT scan that shows a lung, unfortunately, and then a PET scan showing distant. And this is somebody that unfortunately has, advanced cancer at their presentation. They undergo a biopsy, and that biopsy shows that this is an adenocarcinoma. This patient is then referred to a medical oncologist clinic. What additional information am I going to be looking for to decide what's the right treatment for this patient? And ultimately, that's where biomarker testing is really important because, sorry, my point. There we go. For a long time, when we had a patient come to our clinic, we had a pretty broad view of what lung cancer was. It was defined just by a couple of buckets. We had non-small cell lung cancer, we had small cell lung cancer, and then under non-small cell, underneath the microscope, the pathologist would tell us, is it an adenocarcinoma or squamous, and then some other more uncommon histologies. But, ultimately what we've learned from lots of genetic sequencing of cancers, profiling of the tumor microenvironment, this is a pretty simplistic view that patient's cancers are actually quite unique to the patient based off of both genetic characteristics as well as what's in the microenvironment of the cancer. And so, just targeting treatment based off of these buckets really wasn't sufficient to provide a personalized treatment for each patient. So what biomarker testing ultimately does is use either tissue from the patient's biopsy sample or liquid biopsy approaches, which are from the blood, analyze various proteins or genetic changes that may help us ultimately decide what's the most appropriate treatment option for that patient. And there are a couple of different approaches to biomarker testing. We've talked about sequencing approaches. Before we had sequencing approaches, some older techniques that were being used for approaches such as immunohistochemistry, which is looking at proteins on the cancer cells oftentimes, and then other genetic analysis approaches such as FISH testing or PCR, which you've probably seen in some profiling reports that are a little bit older. We've moved now more towards next generation sequencing, with DNA sequencing being pretty commonly used, and now more commonly being looked at is RNA sequencing approaches and what we get from that information. This is something that's done on a tissue specimen. First off, looking at what types of biomarkers we're looking at. So one of the things that's been mentioned before is to look at PD-L1 expression. So PD-L1 is something that can be present on cancer cells or other immune cells in the microenvironment. And that PD-L1 is basically like a stop sign. It kind of impairs the function of the T cells, which is one of the major immune cells that work to clear cancers. And so looking at PD-L1 expression can give us a sense of whether a patient's cancer may be responsive to immunotherapy or immune checkpoint blockade, which are the main types of immunotherapy that are currently being used in lung cancer. So this biomarker is done on a tissue specimen, and the biggest scoring system that we're currently using in lung cancer is something called a TPS score, tumor proportion score, which is something you may see on a report. And that score basically is looking at what percentage of the tumor is expressing this PD-L1 marker. And the higher the level of expression of that PD-L1, essentially the higher likelihood we are to get a response to immunotherapy. With a couple caveats we'll talk about. So that's something that you'll see commonly on reports that are giving what the PD-L1 scoring is. And the caveat to PD-L1 testing is that TPS, or tumor proportion score, is one of the most commonly used approaches. But as a lot of different drugs and combinations have gone through testing, there are a number of different antibodies that have been tested, and there are a lot of different scoring systems. So you may see that you might be looking at PD-L1 on immune cells, or the combination of tumor cells and immune cells. And really, this has been kind of tailored to each different cancer type. So in lung cancer, it may be that we're looking at the TPS score, but a different type of cancer, we're looking at the scoring system. But ultimately, PD-L1 gives us an estimate of the likelihood of response to immunotherapy. But unfortunately, it's not oftentimes 100% correlation because it's a little bit of an indirect marker of immune activation. So even if you have a 90% PD-L1 score, it doesn't guarantee a response to immunotherapy, which is something that's important to consider as you're thinking about these biomarkers. Other major biomarker that we look at in non-small cell lung cancer, and particularly non-squamous non-small cell lung cancer, is genomic profiling, or genetic biomarkers. And that's really because through years of profiling and sequencing of these cancers, we've learned that at a genetic level, these are a very broad and diverse array of cancers that can have a number of different driver mutations. So this is a pie chart that is showing some of the major ones that are both seen in lung cancers as well as potentially targetable with medication. And what you can see from this is that we've been fortunate over the years that starting with EGFR, which was really one of the prototypes of a targetable genetic alteration in any type of cancer, we've come a long way to having a number of different genetic changes that we can find that have targetable medication. And this list is fortunately continuing to expand. So this is where comprehensive analysis and looking at a number of different genes is really important, because while some of these may be rare, when they are identified, they can offer really meaningful therapeutic options. So this has been covered a little bit before, but this is where next-generation sequencing or broader sequencing of DNA taken from tumor specimens has become important in being able to analyze all these different genes at once. So not just looking at specific genetic changes, but looking at the entire gene, so that may allow us to identify more rare variants that are found in these genes. These approaches are higher throughput, and they can do concurrent analysis of multiple genes, whereas before we were doing sort of single gene testing of a couple of the variants that we have medications for. And the advantages of this approach is that with one test, you can get a really comprehensive look at the genetic drivers of the cancer, whereas if you were doing just specific hotspot areas, you may miss out on something that's a little bit rare. For example, EGFR, there's a couple of variants that are the most commonly seen mutations, the L858R variant or exon 19 deletion, but there are a number of other variants that are seen in patients and can be actionable with the medications that are FDA approved. So comprehensive testing really allows us to look at all of these. You know, some of the limitations of these assays that you've seen is that they are pretty specialized. They're done in specialized laboratories, and because of some of the significant computational analysis that is required, there is a turnaround time that we have to be thinking about when we're looking at these tests. So this is all testing that initially we're thinking about doing on tissue, so on a biopsy specimen. But unfortunately, sometimes either the biopsy specimen is not sufficient, or you know, it's difficult to get a biopsy of a site that really gives you enough material to do genetic sequencing. So that's where liquid biopsies or plasma-based testing from a blood test has become really helpful for lung cancer. So these testing approaches use a blood sample that's taken from a patient, and it relies on the fact that cancer cells may shed some of their genetic material into the bloodstream that can be extracted and then analyzed for the genetic changes that are happening specifically in the cancer cells. So circulating tumor DNA can be taken from these blood samples that analyze through genetic sequencing and used to get a picture of what's going on in the cancer cell without specifically a tissue biopsy. And these tests can again be broader sequencing panels that use next generation sequencing, that look at a number of different genes, or they can also be single gene tests, which tends to be more commonly used in clinical trials, not necessarily in clinical use. This is another approach that can be used to get to comprehensive profiling of the lung cancer. Now, when we think about limitations of this approach versus tissue testing, there are a couple of important caveats that are, I think, good to consider. You know, one is the idea of a false negative test. If we have a patient who doesn't have a tumor sample, for instance, and they get a liquid biopsy test, if you don't detect a genetic alteration, it's important to realize that you don't have to stop at that point. Because unfortunately, there is limitations to the sensitivity of these assays. If a patient has a low tumor burden or the specific site of their cancer, they're not getting a lot of shed of the tumor DNA into the bloodstream. The other thing that's important to consider is that because these are blood tests, you have to interpret the results a little bit more carefully. Sometimes you may find things in the blood that is not always derived from the cancer. We all, as we get older, have genetic changes that happen in our blood cells that you may detect in one of these blood tests that doesn't necessarily point to a targetable treatment. So it's something to be considering as you're interpreting these results. And that's because these are novel tests that are usually limited to a certain array of the genetic changes, you may not detect all the possible genetic changes that you would with a more broad tissue. Some curious. And then lastly, you know, one of the things that's important to consider is that the tissue-based testing, in addition to being able to give you genetic information, also gives you information about the histology of the cancer. And we do know that rarely people's cancers can change. So you can have a non-small cell lung cancer that undergoes treatment with a targeted agent and can transform to a small cell lung cancer. And that type of information you can't get from one of these liquid biopsies. So that's something you have to be thinking about if you have a patient in front of you and looking at their scans and how to interpret these. But in general, these tests have offered a lot of advantages for patients where tissue testing can be more limited. And because of that, the International Association for Lung Cancer recently put out some guidelines that I think are pretty useful to be considering as we're applying these tests in the clinic. And so what their recommendations are is that if you have a patient in front of you who has a tissue sample that's been taken and it appears to be sufficient for doing broad comprehensive profiling, then that's probably the best place to start. Proceed with the comprehensive profiling. But if the tissue sample looks like it will be insufficient, for example, if it was taken with a fine needle aspiration, or it's been already used up for other testing to identify what the cancer type is, then maybe it's reasonable to go ahead and also send a liquid test on that patient so that you're not holding up identifying a potentially important biomarker for treatment selection. And I think this is clinically what we tend to do when we see patients with advanced cancer. So the other important part as we think about what comprehensive biomarker testing is to think about what the targets are used for. Unfortunately, the number of agents that have been approved has really expanded over the years. So this is an overview that shows what the current treatment paradigm is for patients that have a biomarker that's identified on genetic profiling. And you can see this includes looking at EGFR mutations, ALK, ROS1, and BRAF, as well as NTRK fusions, and two of the newer players in this, which have had approvals in the past 2 years, are RET fusions, as well as MET exon 14 deletion. And this is all for deciding on first-line therapy for a patient. There are other mutations, such as KRAS mutations, which have recently had drugs approved in the second-line setting and are also important in looking at in terms of comprehensive profiling of patients. These are the genetic changes that I would look for when I was looking at a test. At least these should be looked at in a patient's profile to say that they've looked at something comprehensively. So if we return to our patient's case, they undergo this biopsy showing an adenocarcinoma, and it shows a PD-L1 with a tumor score proportion score of 60%. And they undergo genomic profiling of their tumor, and they identify this KIT5B RET fusion. So we have two different biomarkers here. Which of these are we going to be using in our treatment selection? The PD-L1 suggests maybe immunotherapy, but the genetic change suggests maybe a targeted therapy. And in this scenario, and you were bringing up a good point earlier, what we've seen generally in the clinic is that oftentimes patients that have driver mutation positive cancers or some of the genetic changes for which we have targeted medications for, that trumps the PD-L1. They tend not to respond as much to immunotherapy. And so in this patient's case, we would want to go with the RET fusion as the biomarker to select their initial therapy. And this is a patient of mine who happened to have this identified a couple of years ago before we had RET inhibitors, and was enrolled on a clinical trial at UNC that was testing some of these inhibitors in the first-line setting. So the RET, just to give an example of how these biomarkers can be really useful in treatment selection, I wanted to go through some of the data on RET, because it's one of our newer biomarkers that we've identified, and show how powerful this can be. So this is a gene that's relatively rarely altered in lung cancer, but when it is typically through a fusion event where the RET protein kind of gets altered and hooked up to something that it's not normally hooked up to, and that makes it go kind of all the time where it's activated. It's also found in thyroid cancer, and that can be either by fusions or also mutations as well. So basically, these fusions turn on the RET protein, and now there are two very selective drugs that target the RET protein that have been looked at in clinical trials. So my patient, for example, was enrolled in this clinical trial, which was looking at the agent Pralsetinib. And what this waterfall plot is here to show essentially is that why these targets can be so meaningful, because you can see on these plots that the majority of patients in this trial, which included patients that had never seen a treatment before, but that had already had prior chemotherapy or immunotherapy, had response of their cancer to this very targeted agent, which is really powerful. And that duration of response was for years oftentimes. And the other important part about some of these therapies is that they can have responses in the brain, whereas a lot of our older chemotherapies are often effect in terms of brain metastases. So that's where identifying these can be really helpful. You can have a patient that's found to have brain metastases. Maybe they're not going to need brain radiation. Maybe they can be treated with one targeted agent, and that's going to be effective for treating the brain cancer, brain metastases as well. And then this is just data for the other drugs that have been approved for targeting RET fusions, Pralsetinib. And again, just showing the idea that previously treated patients, newly diagnosed patients, these very selective drugs can have really significant activity with long durations of responses and activity in the brain as well. So, briefly summarizing, comprehensive biomarker testing is really important because of data like this, because we have drugs that we can identify that can really treat patients selectively for their individual cancers. PD-L1 is really important for being able to select patients for immune therapy, deciding on whether immune therapy alone or immune therapy plus chemotherapy is the best initial treatment approach. And then genetic profiling is important for identifying if they may be a candidate for a targeted agent. And the genes that would look for should definitely be included in a comprehensive panel: EGFR, ALK, ROS1, BRAF, NTRK, MET exon 14, and RET. Those are drugs that we have first-line indications for. And then KRAS is also important because we have an agent that is now targeting KRAS, which is pretty amazing considering how long KRAS has been considered untargetable. And then, comprehensive testing that includes emerging biomarkers can also be helpful because while there's not currently approved drugs for mutations in genes like HER2, that's really becoming an emerging target with promising data, and identifying some of those can help qualify patients for clinical trials with these agents. So I will stop there.
All right, so I'm Terry Conneran, and I thank you guys for having me here tonight, okay? And the talk is really, truly, cancer is personal. I'm the person in the personalized medicine. And how I ended up finding out or getting involved in any of this is I got diagnosed with lung cancer. And I was kind of looking for something to do as my youngest one was about to graduate from college. Yeah, this was almost 5 years ago. And I ended up getting the diagnosis. So I get diagnosed with lung cancer, go through treatment, trust in my doctor, find out everything that I need to know. And after surgery and chemo, what have you, I had no evidence of disease. I moved on with my life. But I needed the time to process this, so I got involved with lung cancer support groups. I was in lung cancer support group. So, about 9 months after the diagnosis, I was involved in a lung cancer support group, and I started hearing people breaking up. I'm this, and I'm that, and I'm this, and I'm that. And I'm like, well, okay. I started learning about biomarkers and able to process all the things that I had just been going through, and found out that there's biomarkers and there's biomarker groups. So I wanted to connect around people and went to the first big summit, and there's 400 people there. Actually, I was just left, met up there at the summit, and they were all profiled in the groups. There's EGFR people, and there's the ALK people, and there's the this people and that people, and I don't know what I am. I don't have any people. So I go back to my doctor's school. What's my biomarker? My doctor doesn't tell me my biomarker is. You don't have one. Maybe I don't have one. I don't have a biomarker. No, you just got this PD-L1. Oh, okay. Fast forward, I'll bore you with the rest of the story. It took 3 years. So I went to Chapel Hill to get a second opinion, and after 3 recurrences, and said to the doctor, because by now I've become very involved. I'm on a board, a lung cancer support group. I've been here, been there. I've attended, well, before we did Zoom, we did in-person meetings. And I said to my doctor, well, it's not like I have a biomarker. Well, yeah, you do. You have KRAS. All I know is that's not good. Okay, I'm KRAS. Friday night, I go home. Well, there's EGFR people, there's ALK people, there's KRAS people. All I know is KRAS is bad. So I go home, okay, let's see if I can get this split dance. And I went looking for, let's see, I did it wrong. Did it wrong?
There you go.
There we go? Okay. So I go home and let's see. All right. Okay. So I went home looking for the KRAS people, looking for the KRAS group. Oh, KRAS group. Okay, well, let me research this and see what's going on. KRAS is undruggable. KRAS wasn't just found. They found it 40 years ago. This isn't just like some schlock saying KRAS is undruggable. These are the doctors. These are the researchers. These are the clinicians. And they're telling me that what I have is undruggable. And I'm sitting there, I just heard I'm NED again after 3 years. And I just found out that this thing was there. And by the way, my second opinion doc pointed out to me, it was on my original report. Now I know what I am. Now I know the name of the demon that I'm fighting inside of me. So I want to find the other people so that we can kind of build a sense of community around the same thing, the same common enemy.
There wasn't a group. So just to put this into perspective, I found this out just as China's starting to see this weird flu thing starting to happen, okay? And in January, I was able, that's when I started, in January of 2020, started the KRAS Kickers online as an online virtual support group to connect people together so that we could fight this common enemy, so we could share the knowledge and the information and the resources to kick cancer's KRAS. There goes the name KRAS Kickers. You're going to see a lot of the slides I wasn't sure what everybody's going to cover, but you're going to see that there's biomarkers out there, right? These are, I swiped slides from only the best people, so these are some of the folks that we recently had. But you're going to see up there all these different groups, okay? So here's, you can't see this is not real good. All the lung cancer, right? This kind of a little bit squamous. Like then you break up into all these groups and see all these things here. Look at all those targeted therapies. And of the KRAS, okay, you see that we're the largest group. We're the largest group of individual cancer. And by the way, that doesn't apply just to lung. It's pancreatic, it's colorectal. So we're like the top three. We don't even have an excuse not to be getting any sort of information. So they've been looking for us. They haven't been able to do anything. I am really stuck with this slide thing. Got you. Okay, all right. Well, we're just going to leave it there because that way I can just talk to it. Okay. So, well, you just got to go with what you got. Okay. So I found out what I am. I found out the name of what I am. And I wanted to build people and a sense of community around it. And so since during COVID, what have I been up to? I've been building a community around KRAS. And so I'm, by the way, no, I'm not KRAS G12C, which happens to be the larger percentage of KRAS that has its first drug for second-line therapy. I'm the most common of all KRAS, KRAS G12D, which means that I'm fortunate that it hit my lungs. If this hit my pancreas like it does 90% of the time, I wouldn't be here today. Talk about an opportunity to kind of like share, and you start recognizing the level of importance of what's happening, that it's not what I did or what I didn't do. It's not if I smoked or didn't smoke. It's not if I was breathing or not breathing. This is a mutation. This is above and beyond just a what if. This isn't something I did to myself or I ate sugar or something. This is just what it is, and this is what it's meant to be. And that's a part of what KRAS Kickers has become. KRAS Kickers has become an opportunity for people to connect around the information, to be able to bring in the information, the resources, and the research from the doctors, from the clinicians, from the pharmaceutical companies, from the clinical studies that we're desperately trying to find because we can't get access to the information. We can't find it. And the patients and the caregivers and the care partners are desperately searching for this information. And the KRAS Kickers is that sweet spot in the area of it to bring those two sides together so we can share the information and share the data. We need to know. But you know what? It all boils down to, and I mean, it couldn't even be any better. It boils down to us got the people to hear that we need it. We've got the foundation. We've got Tempest here. Y'all are the ones that do the biomarker testing. We've got a doctor here. You need to tell the patient what we are. The sense of identity. I walked into a room of 400 people, and they were all broke up into different groups, and I didn't know what I was. Yet, I've already feel alienated and alone and terrified. And if I was to go online and start looking for information as far as what to do for a treatment, I don't know what I'm looking at. But if I know that it's KRAS, I know I'm not EGFR. I know I'm not ELK. I know as much as I love those people, and I do, I love you all, you guys have different treatments, you have different issues. And some of you look a whole lot better in the picture than I do, but you have other things. And we want to be able to share that knowledge. And so what we ended up doing is now KRAS, which is starting to get a lot of press, you know, it's only a second-line therapy. It's only not even 50% of the lung cancer that's got a second-line therapy. We're connecting the KRAS Kickers is connecting all the KRAS around it because we're finding that it is so difficult for us to be able to get the information, to find the information, to be able to connect around it, that we need to be able to find that at a patient level, at a grassroots level. The organization, the industry has been fantastic about being able to help. I'm all for research. We're all for clinical studies. We're not funding it because we want to be able to bring the information into the clean level so that we can let places like the initiative do what they need to do and do the research and work together, and we can work alongside each other.
I want to be respectful of everybody's time. This has been a great discussion, and I've got all these ideas of things that LCI can do in partnership with you all. I mean, you're talking about what to ask. I mean, maybe looking at our journals and seeing, you know, do we have all the questions in there that patients need to be asking? I mean, there's so many things, and I just want to thank everybody because you were all part of the discussion, and I think we would like to lean on all of you to help us continue to raise awareness about comprehensive biomarker testing. But thank you so much to our panelists, because this was a wonderful discussion, and I think there's going to be many more discussions to come. Thank you to our online folks. I don't know if they're still with us, are they? Well, thank you for all of you joining us online. We really appreciate it. And again, we look forward to doing more of these types of programs in the future. So we'd love to hear from you all about the topics that you want to learn about. And I'll say one final thank you, too, to all of our sponsors and supporters for helping to make tonight possible and all of our educational events possible. So thank you for coming out. It was great to see you all in person, great to see you all online, and we hope we get to see you all again soon. Thank you very much.